eminent faculty members and participants who have joined from India, Asia, and various parts of world. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Farhad Rawandi, all discussants and participants to this virtual symposium on clinically relevant advances in the treatment of AML. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a very passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Dinesh ki also hai.
Thank you, Mr. Sumit Madan.
Are you?
Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Farhad Rawandi from Houston, Texas, USA, and he's going to lecture us on clinical relevant advances in the treatment of acute myeloid leukemia. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Farhad Rawandi Kashani from Houston, Texas, USA. All our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 3rd of March 2024, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on first-line therapy of Hodgkin's lymphoma by our guest speaker, Professor Jurzak from Poland. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhijit Giram from Saidri Hospital, Pune, Dr. Aditi Jain from VMMC and SJH, Delhi, Dr. Akash Khandelwal from Faridabad, Haryana, Dr. Amrita Chakrabarti from Max Hospital, Shalimar Bagh, Delhi, Dr. Ankur Ahuja from AFMC, Pune, Dr. Gaurav Dixit from Artemis Hospital, Gurgaon, Colonel Dr. Kundan Mishra from RNR Army Hospital, New Delhi, Dr. Lalit Kumar from All India Institute of Medical Sciences, Delhi, Dr. Mohammad Rizwan Sheikh from Sheikh GSMC and KIM Hospital, Mumbai, Dr. Mona Vijayaran from SGPGI, Lucknow, Dr. Mukul Agarwal from AIMS, Delhi, Dr. Nikhil Kumar from AIMS, Delhi, Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur, Dr. Nitin Dayal from Max Super Specialty Hospital, Saket, Delhi, Dr. Pavan Kumar Singh from BLK Max Super Specialty Hospital, Delhi, Dr. Rahul Arora from RST Hospital, Nagpur, Colonel Dr. Rajan Kumar Kapoor from RNR Army Hospital, Delhi, Dr. Rajkumar Ramaswamy from Velamal Specialty Hospital, Madurai, Dr. Ranjit Kumar Sahu from IRCH AIMS, New Delhi, Dr. Sandeep Partake from Bharati Vidyapit Medical College, Pune, Dr. Sanjeev Kumar Sharma from BLK Max Super Specialty Hospital, Delhi, Dr. Varun Bafna from Dr. Bafna Star Clinic and Hospital, Kolhapur, Dr. Vishwadip Khushu from AIMS, Nagpur. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Farhad Rawandi Kashani from Houston, Texas, USA. Dr. Farhad Rawandi is Chinese and Stephen A. Lesher Professor of Medicine and Chief of Section of Developmental Therapeutics in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. He graduated from the University of London, England, and undertook residency and fellowship training at the Baylor College of Medicine and the University of Texas MD Anderson Cancer Center. During this time, he specialized in the management of hematological malignancies and stem cell transplantation. He then joined the University of Illinois at Chicago as the Director of Leukemia Program and the Interim Director of Stem Cell Transplant Program for 3 years until he joined the Leukemia Department of MD Anderson in 2003. He is also board certified in internal medicine, hematology, and medical oncology. His main areas of interest are therapy of AML, as well as other leukemias, including Ph-positive ALL, hairy cell leukemia, and T-cell leukemias. He has authored several book chapters and many articles in peer-reviewed journals. He is a member of several professional societies, including the American Society of Hematology, American Society of Clinical Oncology, and Society of Hematological Oncology. He is a member of editorial board of several journals. And today he's with us and he's going to lecture us on clinical relevant advances in the treatment of AML. Well, thank you so much. Over to you, Professor Dr. Farhad Ravandi.
Good morning, and thank you very much. I'd like to thank Dr. Agarwal, who invited me, and as well as the committee that has brought me to speak to you about clinically relevant advances in treatment of AML. Let me try to share my slides. Sorry, 1 second. I don't know why it's not. Do you see my slides?
Yeah, they're not in slideshow mode.
Yes.
Yeah, I'm trying to put it on slideshow and it doesn't go. I did it earlier.
Yeah,
Okay,
yes.
that's fine.
Perfect.
Okay, and so I'm going to talk about recent advances in management of patients with AML. Like anything else, I think it's always better to start with history, and you probably have seen this slide. This is from the 1990s, where in our institution, it was shown that patients with AML, despite getting a similar therapy, and that's essentially was RC and anthracycline-based therapy, can have very different outcomes, clearly based on the cytogenetic features of the disease. So we have known for a long time that AML probably should not be considered as a single disease, but a multitude of different diseases. Of course, with increasing sophistication of our assays, as well as with the groups being able to develop large databases, clearly became more and more evident that there are many different cytogenetic abnormalities. Again, on the left, as you see from Dr. Greenwade's paper, with significantly different outcomes when patients receive exactly the same therapy. And on the right, more recently, with the development of molecular assays, we now know that there are a number of mutations as well as cytogenetic abnormalities that happen in AML patients recurrently. This is now being recognized by the classifications of AML, where increasingly we are identifying subsets based on the molecular and cytogenetic abnormalities, and we have started defining specific disease entities. And I'm sure you all know that this started in the earlier versions of WHO and ELN classification, initially, especially with core binding factor leukemias. But now this is expanding all the time, and we are identifying very specific subsets based on their chromosomal abnormalities and more recently mutation that they have. And this is going to expand even further. This is again from the international consensus classification, where you are finding other specific cytogenetic abnormalities which provisionally will become specific entities. And the reason why this is important is because with the understanding of the molecular basis of these abnormalities, we are developing specific molecularly targeted agents. And I think the most recent example of that is menin inhibitors, which are beneficial both in KMT2A or MLL rearranged leukemias, but as well as other specific subsets, such as NUP98 translocated leukemias. So increasingly, the AML classification is moving from morphological to genetic classification. And I think we all agree that this makes sense because, for example, blast percentage, many of you will remember that we used to define AML patients by having more than 30% blasts until we decided that 20 to 30 is equivalent to more than 30. So the baseline for AML definition became 20%. But as you see here in the more recent ICC and ELN classifications, we are actually beginning to identify patients with 10 to 20% that can have potentially similar outcomes with AML patients. And again, this is going to be more and more reliant on the molecular and cytogenetic findings as we understand more and more about these patients, and more importantly, as we develop specific therapies. Because if you have a specific strategy, and the best example of that is APL, it doesn't matter if you have 11% blast or 21% blast or 30% blast. So there has been really a revival of interest, I would say, in treating patients with AML in the last 6 or 7 years, mainly because we had very few new drugs being developed in AML or for AML therapy. And some of us, like myself, were very frustrated because we had very high bars for getting new agents in AML until about 2017, where we started having a whole host of new agents, starting with midostaurin for FLT3-mutated AML, and then more recently, a number of FLT3 inhibitors, as well as IDH inhibitors. And you see on the right, the list can be expanding. There are menin inhibitors that potentially may be approved. We have oral azacitidine approved for maintenance therapy in AML. And there's a number of targeted agents that have been developed. And I think probably one of the most important ones is venetoclax, which I will show you later, has clearly shifted the landscape in AML therapy. So we've been relying on 3+7 now for about 50 years. And at MD Anderson, especially, and probably some others will agree with us, we would like to retire 7+3 and have new strategies for frontline therapy of AML patients. This regimen has really served us well over the years and continues to be the basis of therapy for AML in most countries around the world. But I think we will eventually change this strategy with the development of new agents. Of course, even with 3+7, we are already adding agents in specific subsets. This is from the Ratify trial, where clearly was shown that adding a FLT3 inhibitor, midostaurin, was beneficial for FLT3-mutated AML patients, both FLT3-ITD and FLT3-TKD. And of course, this has been the sort of a standard of care in the US for the last 6 or 7 years. I actually think midostaurin is not the best FLT3 inhibitor, and we are, I think, fortunate that quizartinib is now coming on in the armamentarium. We started developing quizartinib at MD Anderson in early 2000s, and some of you may know the history. It has been a very painful process to get quizartinib approved, mainly because of the toxicity of QTc prolongation and because the dosing, we were testing very high doses in early phase 1 and then phase 2 studies. This was the Quantum First trial that was published last year, randomizing patients with AML with FLT3 ITD only. So this drug does not work on FLT3 TKD. So FLT3 ITD mutated patients between the ages of 18 and 75 years were randomized to receive either 3+7 plus placebo or 3+7 plus quizartinib. And then they could continue with high-dose cytarabine consolidation, as well as potentially allogeneic stem cell transplant if it was available. And then following the completion of the consolidation or after transplant, they could receive quizartinib for 3 years. The dose of quizartinib here is significantly lower than, for example, the doses we used in our phase 1 studies. As I mentioned, we went up as high as 200 milligrams, and the main problem was QTc prolongation. Now, this study is very similar to RATIFY with some major exceptions. In the RATIFY trial, if you remember, we did allow both FLT3 ITD and TKD, and the upper age limit for enrollment was 60. So it was no patients above 60 that were enrolled in the RATIFY. Here, they actually continued quizartinib even if the patients went on to have a transplant. And actually, in this study, they actually encouraged patients to have an allogeneic stem cell transplant in first remission if this was possible, which was a little bit different than from what it was in the RATIFY. Now, this study was a positive study showing a significant improvement in overall survival for patients who received quizartinib, as you see here. And I do want you to notice the beginning of this Kaplan-Meier curves, where quizartinib arm appears to be a little bit worse. Of course, this is just on the visual thing, but it is important to remember that quizartinib is myelosuppressive, and so particularly in the elderly population, in the early part, there was more myelosuppression and myelosuppression-related toxicity. And this is why I would advocate not to use quizartinib with 3+7 in patients above 60, and I'll come to that a bit later. Now, this study was very important because it showed allogeneic stem cell transplant in first remission was highly statistically significantly associated with improved survival, as well as taking quizartinib. So it was positive in terms of quizartinib and led to the approval of quizartinib. But as you see at the lower part of the figure, transplant was highly significant. So this is why we in our department advocate transplanting all patients with FLT3 ITD as soon as it is possible, and we really try to push for this transplant. And this is another way of showing this. Again, if you see here in the two arms of the study, the green ones are the placebo arms and the blue ones are the quizartinib. But the straight lines are the ones who had transplant. And you see that in both situations, the transplanted patients did better. And even you could argue that the placebo patients who had transplant actually appeared to be doing pretty well compared to the ones who didn't. I think another reason this was a very important study is because the concept of MRD in AML, we will talk about later, but this was a first randomized prospective trial where they used a molecular MRD assay for FLT3 ITD. This was a very sensitive assay with a level of detection down to 10 to the minus 6. And they did show clearly that patients who became MRD negative had significantly better survival at all the time points that they're looking at here after induction, after 2 cycles of chemotherapy, or after the last consolidation cycle. clearly, patients who were MRD negative at a level of 10 to the -4 did better. And then with the complete MRD negativity also, the patients who became negative. When you look at this, bringing quizartinib into it, you see that patients who received quizartinib had deeper MRD responses, again, at all these time intervals where they looked at these patients. So if you look at all of these, there is statistically significant advantage for the quizartinib-treated patients in terms of reducing the burden of the disease as measured by the molecular MRD assay. So again, another evidence that quizartinib is effective, and what it does is it lowers the disease burden and lowers the MRD level. This is also very important because here they showed that if patients were MRD positive, quizartinib was highly beneficial in improving survival. However, the patients who became MRD negative, you see on the left, quizartinib doesn't seem to be producing as much advantage. So this becomes a very important point because I think, as we've seen in Philadelphia positive ALL, I think it's becoming more and more important to really focus on this MRD assays, try to develop better and deeper and more sensitive assays to try to guide therapy in patients. Again, showing this in a similar way, this is showing, again, quizartinib-treated patients in the MRD negative setting weren't benefiting as much, whereas the MRD positive patients, quizartinib was significantly improving their outcomes. What about the patients with other subsets of AML? So, FLT3-mutated or FLT3-ITD AML is only about 25 to 30% of patients. This is where I think venetoclax has been revolutionary. I'll talk about the older AML, but this in the younger AML, we also added venetoclax to intensive chemotherapy. Now, we use a very intensive chemotherapy for our younger patients anyway. That's the FLAG-IDA regimen, or CLIA regimen, which is a very similar regimen with cladribine instead of fludarabine. And as you see here, in both of these cases, we use venetoclax. Now, initially, we were doing longer venetoclax, but I would also advocate that if you're ever going to do this, 1 week of venetoclax is enough. And here in the CLIA, we also used 1 week of venetoclax. The chemo is very intensive. Cytarabine dose is a 1.5 gram per meter squared. Idarubicin is 10 for 3 days. In consolidation, of course, all of these agents get reduced. I would tell you both of these regimens are very myelosuppressive. We treat patients in the hospital. We keep them for the entire period until the count recovery in the hospital. It can be toxic if you're not careful, and you can get patients into sepsis situations, etc. So again, this is a regimen that I would only advocate using in specialized centers and with the hospitalization of patients. But when we do this, you see here are historical patients with the similar intensive chemotherapy, again, high-dose Ara-C plus anthracycline based chemotherapy, essentially FLAG-IDA, compared to patients who had the same regimen plus venetoclax. And as you see here, there is a significant improvement in response rate. Here on the right, we had a significantly higher patients going to allogeneic stem cell transplant. And this is the most important. You see the relapse rate is significantly reduced when you add venetoclax to this intensive chemotherapy. Again, this is only in younger patients up to the age of 60, as long as they also have no comorbidities. And this translates to better survival, and particularly if the patients also go on to have an allogeneic stem cell transplant. This is intensive strategy for treating frontline younger patients AML, but it is pretty successful. You can see the survival here. It's at 3 years is about 70%, which is we've never seen this in AML. What about all the patients? I think, again, venetoclax has been revolutionary. You know that in elderly AML, we used to be having a lot of problems because they can't tolerate chemotherapy. And so the AZA plus venetoclax has been essentially revolutionary. This is the VIALE-A long-term follow-up. You see that the overall response rate was about 70%. And however, with long-term follow-up, unfortunately, we still are only curing 20% of patients. Now, I would tell you that, of course, some of this is because many of these patients are 80 and 75 and older, and many of them probably pass away from other comorbid conditions and not necessarily from their leukemia. So the fact that we are getting really elderly and unfit patients and curing at least 20% of them itself is very important. But I think we need to do better. We need to, for example, in APL, age is really becoming irrelevant because even in the elderly population with APL, with atro and arsenic, we can actually cure patients. And we need to do that in other AML as well. This is a presentation in ASH a couple of years ago, looking at the VIALE-A AZA plus venetoclax treated patients. And they did show that the important predictors of outcome are presence or absence of these mutations. So P53 mutated patients do very poorly or worst. Patients who have FLT3-ITD or RAS mutations are still not that great. All the others, the ones who don't have these mutations, do the best. And among these are the NPM1 and IDH1 and IDH2 mutated patients who do the best using AZA plus venetoclax. So I think when you look at these curves, and again, if you are a person who wants to make the survival curve in AML a straight line, we really need to do better in all of them, but particularly in P53 mutated as well as in FLT3 and RAS mutated patients. So in the FLT3 mutated patients, we did have options. And so a couple of years ago, Nick Short and I started developing this regimen in our institution, essentially adding gilteritinib to AZA plus venetoclax. This is only in FLT3 mutated patients, and we do a bone marrow on day 14, and if the marrow is clear, we stop both gilteritinib and venetoclax. If it is not clear, we continue them, and then we repeat the marrow a week later to see if we are emptying the marrow from leukemia cells. And the reason for that is again, this is can be very myelosuppressive, and we want to stop both the venetoclax and gilteritinib as soon as we don't feel they are necessary. In consolidation, we give lower doses. AZA is 5 days only, and venetoclax is only 7. And I would tell you, this is very patient dependent. In some more frail patients, we might even reduce this. Gilteritinib will go continuously. Once the patient is in remission, we just continue 80 milligrams of gilteritinib continuously. We have published this now in JCO a couple of months ago. You can see the manuscript for yourself. In the publication, you'll see we had 30 frontline patients, and we did also treat some relapse and refractory patients. In the frontline setting, the outcome is outstanding, essentially everyone achieving a response. And these are very durable responses. You can see, and again, remember, these are FLT3-ITD mutated patients, and only some of these patients went to transplant. Many of them did not. And you see that the survival curves are becoming straight lines. So it has been a successful regimen that we continue to use. Remember, I showed you the Quantum First trial, and I mentioned in the patients over the age of 60, I do not advocate using quizartinib plus chemotherapy. This is what we use for older FLT3 ITD and FLT3 TKD mutated patients. This is the less intensive and, in our opinion, as effective and probably more effective than frontline chemo plus FLT3 inhibitor. Just to show you the importance of MRD, again, we did use the same assay that I showed you in Quantum First. It's a very sensitive NGS-based PCR assay for FLT3 ITD. And you see here that we are getting undetected levels. Remember, the depth of detection in this assay is 10 to the -6. So we are getting undetectable levels in patients who are getting this strategy. And among the 20 FLT3 ITD patients, you see at cycle 4, 65% they became undetectable at very low levels. So this is another reason why I think these lower intensity regimens are going to become more and more important. So we are starting to think, well, can we use this regimen even in the younger FLT3 ITD mutated patients? If you imagine, if you are going to transplant the patient, which we advocated that we have to transplant all FLT3 ITD patients, why not give them a lower intensity regimen that is actually very effective and can produce undetectable MRD levels, and then subject them to transplant? You know that you don't want patients to get toxicity before transplant, so a lower intensity regimen would likely be something that you would even consider in the younger patients, as long as you have proved it is as effective. And this is where MRD assays become important. What about P53 mutated AML? Here, Dr. Daver in our group was championing this drug magrolimab, which we also added to AZA plus venetoclax to older P53 mutated patients. And unfortunately, this drug so far hasn't made it. The randomized studies that I've done so far have not been positive. We do need a strategy in P53 mutated patients. You all, if you all have treated P53 mutated AML, you know this is a very bad disease. We really need to improve things. I still advocate using AZA plus venetoclax. People will tell you that AZA plus venetoclax does not improve survival, and I agree with that, but AZA plus venetoclax gives a higher response rate than AZA alone, about 50%. And in my opinion, you need to get these patients to remission and then transplant them as soon as possible if you have any hope of getting a long-term remission. What about the group that I told you does best with AZA plus venetoclax? This is IDH1 and IDH2 mutated patients. And we also have what we call a triplet regimen for these patients. So essentially, we add ivosidenib for IDH1 mutated patients or enasidenib for IDH2 mutated patients. And this has been also very effective. I don't have the data to show you, but I can tell you that this is particularly effective, mainly because ivosidenib and enasidenib are not very toxic and they're well tolerated, so you can easily add them to AZA plus venetoclax. Now, there are people who say, well, why don't you use that as a sequential for patients who relapse? I would tell you that at our institution, the philosophy is the best time to treat AML is the first time. You want to give a tolerable and effective regimen in the frontline setting to reduce the risk of relapse, and this is why we do this. There's another triplet regimen that we use, and that's a combination of cladribine and low-dose Ara-C plus venetoclax, alternating with AZA plus venetoclax. Now, you may be familiar with VIALE-C trial that was published by Andrew Way, showing low-dose RC plus venetoclax, and it wasn't as good as AZA plus venetoclax. However, when we add the cladribine to low-dose RC and then add venetoclax and then alternated with AZA plus venetoclax, we are getting very outstanding results. This is in 60 patients. This is also published in JCO a couple of years ago. You can see that the response rate is 93%, and many people become flow MRD negative, and this is translating to excellent long-term survival. Now, remember, these are all elderly and unfit AML patients, so a 24-month 64% survival is excellent. Even here, subsets are important. So the more favorable ELN patients, the blue line, does extremely well, whereas the less favorable and adverse patients do worse. What about NPM1 mutated AML? And this is something that you will likely to hear more and more over the coming few years, and that's the development of menin inhibitors. These drugs have been shown to be effective in the relapsed setting, in the phase 1 setting. They are effective both for KMT2A or MLL rearranged leukemias, as well as for NPM1 mutated AML in the relapse setting. So these produce very high response rates, and we are already beginning to combine these, and there are several of them available, but they are being combined both with chemotherapy, similar to the FLT3 inhibitors, as well as with AZA plus venetoclax. And so you will hear more about using these agents in the frontline setting in combination to try to improve the outcome of KMT2A rearranged, as well as potentially NPM1 rearranged, NPM1 mutated patients. As I mentioned earlier, I think the best time to treat AML is the first time. This is on the left data from all patients at a specific time period. And on the right, here at the institution, on the right, you see the patients who relapse. Outcome is poor, very poor. Even at our institutions where we have all the best and latest drugs available, we don't want patients to relapse, because when they relapse, their 1-year survival is only about 20% or even less. So we do need to develop best strategies in the frontline setting. And also, once you achieve a remission, we have to try to maintain this remission with good strategies if they are available. And there has been an evolution in maintenance therapy in AML. The Quasar AML 001 trial did show that using oral azacitidine or Onureg is beneficial in terms of improving survival of patients with AML treated with chemotherapy, essentially 3+7, with or without consolidation. So this was approved in the US. And in other settings, this is in FLT3 mutated AML, and this is a German study that again showed sorafenib was a very effective agent post-transplant in FLT3 mutated patients in the setting of maintenance. So using 2 years of sorafenib after transplant really improved relapse-free survival in these FLT3 mutated AML patients. So I think with the development of new and effective targeted therapies, which are relatively non-toxic, I think the area of maintenance therapy in AML is going to expand. You all are probably familiar with maintenance therapy in ALL. We've been doing maintenance in ALL for 60, 70 years. But in AML, we have never had non-toxic and effective strategies. And this is why maintenance therapy hasn't been that big in AML. But I think with these new agents, maintenance therapy is finding a role in AML as well. Going back to what I mentioned about MRD, that's the other area that is, I think, is extremely important. This is a paper that we published in JAMA Oncology a few years ago, showing that on a meta-analysis of all the AML MRD publications, patients who become MRD negative by any assay did significantly better in overall survival and disease-free survival than patients who were MRD positive. Clearly, the FDA needs to agree with us. So far, they have not, but there have been efforts to show this. So this was a recent study, it hasn't been published yet, but this is the BMT-CTN Morpho study, where they looked at FLT3-mutated AML patients, and these patients received chemotherapy followed by allogeneic stem cell transplant. And then after transplant, they were randomized to either receive gilteritinib maintenance or no maintenance. You see here, the study was declared as being a negative trial because the p-value just didn't make the magic 0.05 value. On the right is important that in this study, they also used that very sensitive MRD assay that I mentioned earlier, down to 10 to the minus 6. On the right, you see the patients who were MRD positive, either before transplant or after transplant, before randomization. That's before being randomized to gilteritinib or placebo. The ones who were MRD positive had a highly significant survival benefit from receiving gilteritinib. The ones who were negative really did not get any benefit from gilteritinib. Again, this shows that MRD is important even in maintenance. And I showed you the quantum first data earlier, again, showing that we can use MRD assays even for selection of therapy, and MRD monitoring is important in this disease. Again, this is the same thing that I just showed you, but looking at the details of the study, MRD positive prior to transplant still benefited from gilteritinib, MRD positive post-transplant, and pre-randomization significantly benefited from gilteritinib. And if you look at the MRD levels at 10 to the minus 4, 10 to the minus 5, 10 to the minus 6, undetectable, these are all predictive of outcome. This is in the placebo arm. Even in the placebo arm, if you became undetectable, you had a significant survival advantage. In the gilteritinib maintenance arm, you still benefited the deeper your MRD clearance, but when you superimpose this, you see that the gilteritinib is definitely beneficial. So again, I want to keep emphasizing that, in my opinion, when we can assay it, MRD is very important in AML, and flow MRD has been useful, but I think molecular MRD assays are going to be even more important. And this is going back to the quantum first trial that I showed you earlier, again showing that MRD negative patients did significantly better, and MRD negative patients did not benefit as much from quizartinib than did the MRD positive patients. Other studies have also looked at MRD in AML. This is an important paper that was published in JAMA from the NIH group, looking at peripheral blood samples, which they looked for presence of NPM1 or FLT3 ITD mutants in the peripheral blood prior to transplant. These are patients who were treated in various transplant centers in the IBMTR, or International Bone Marrow Transplant Registry. And they did show that patients who had detectable mutations had a much higher likelihood of relapse after transplant and worse survival than the patients who were undetectable in the peripheral blood samples taken before transplant. Other relevant points about MRD, it was actually in this year's ASH that this study was presented by the UK group. This was as you know, UK NCRI always does very large studies with multiple elements into the study. But this study, they looked at patients, and these are mostly older patients, typically above 60, 65. They received chemotherapy, and then they looked at their bone marrow, and if they were CR MRD negative by flow, they just continued their strategy. Whereas if they had flow positive MRD or unaccessible specimen, the bone marrow, they could not confidently say this is MRD positive or negative by flow, they would be randomized to either just continue standard or get FLAG-IDA or get addition of cladribine to the daunorubicin and Ara-C. So essentially, the question of this study was, does intensification benefit MRD persistent disease at the time of remission? And they clearly showed that in the patients who were MRD positive, as is by flow, and these are the definite patients, not the ones who were indeterminate, the ones who were definitely MRD positive by flow did have significant improvement in their outcomes when they did intensify subsequent therapy with either FLAG-IDA or the addition of cladribine, daunorubicin, and Ara-C. So this was a question that has been asked for many years, that, what's the point of looking for MRD by flow if you're not going to do anything about it? And this study just tells us that you should try to intensify. These are, again, in older patients, to try to eradicate the MRD. And to be honest with you, the best thing that we are going to have in the future is a specific MRD eraser, something that we have in ALL with blinatumomab, but it's been not yet available, and hopefully we will have something similar to blinatumomab in AML to eradicate MRD, because I think that will definitely improve patients' outcomes. Another study, just to show you the importance of MRD, this is a Italian study where in the ELN intermediate risk patients, they looked and if they were in CR, if they were MRD negative, they gave them autologous transplant. If they were MRD positive, they gave them allogeneic stem cell transplant. And they essentially showed that the outcomes were similar. So you could actually spare these patients an allogeneic stem cell transplant and just use autologous if they are MRD negative. So clearly, again, another strategy that uses MRD. What about lower intensity therapy? Is MRD important in patients who are treated with AZA plus venetoclax? And this paper published in JCO clearly answers that. This is from Viale A trial, and they looked at flow cytometry MRD. And you can see, even with AZA plus venetoclax, if you achieve MRD negative status in the CR setting, you do significantly better in terms of overall survival. And this is important, the most important predictor in multivariate analysis, becoming MRD negative. What about molecular MRD in lower intensity patients? This is from Richard Dillon in the UK. They looked at patients who had NPM1 mutated AML, and they received either AZA plus venetoclax or low-dose Ara-C plus venetoclax. And in these patients were monitored by molecular NPM1 assay, by PCR for NPM1. Again, the patients who became MRD negative for NPM1 did significantly better than the ones who remained positive, both in terms of relapse and event-free and overall survival. So MRD assessment is also important in lower intensity therapy. I actually showed you our study of AZA plus ven plus gilteritinib, that we can actually use a FLT3 ITD MRD, even in that study in the lower intensity, and show that some patients achieve MRD negativity. Another area that would be, in my opinion, could be a future of AML, at least in the older patients, is using oral hypomethylating agents. Dr. in our group has been pioneering development of oral hypomethylating agents, oral azacitidine or Onureg that I showed you in maintenance therapy in AML, and then oral decitabine that is approved in the US for MDS and in Europe for both MDS and AML. And we have been advocating the use of these agents in the older unfit AML patients. So we have this regimen of oral decitabine given for 5 days and venetoclax. We are holding the venetoclax on day 21 after doing a bone marrow, because again, this can be myelosuppressive. And in consolidation, we reduce the doses in some patients, significantly reduce the doses. In the frontline setting, in about 50 patients, we also included patients with prior MDS who had received prior decitabine or azacitidine. So this is a particularly poor group of patients who have very poor survival of only about median of 3 to 4 months. But we allowed them to go on the study. And the reason why I say that to you, that we have excellent response in these, I'm focusing on the frontline setting. We have an overall response of 64%, a CR/CRi of 57%, which is a little bit lower than the VIALE-A, the AZA plus venetoclax, and the early mortality is a bit higher. But I would tell you that this group had a median age of 80, about 5 years older than VIALE-A, and it included these patients who had prior HMA therapy. And this is the particularly bad group of patients. When you remove those patients from the analysis, the median survival is very similar to the VIALE-A. So this is a potential strategy for very elderly patients. Essentially, it is the HMA plus venetoclax with all the treatment being given orally, which is, I think you all agree, that huge advantage for older patients, because they cannot keep coming to the treatment centers to get their decitabine or azacitidine. We are also developing triplet regimens with this all oral therapy. We have a oral decitabine, venetoclax, and gilteritinib in FLT3-mutated AML. Sorry, the last one that I showed you, this one is just being published in Lancet Hematology. So this is also ongoing study. We just submitted an abstract to EHA in about 30 patients. You would see it. And there is also a study of oral decitabine, venetoclax, and IDH inhibitor in IDH-mutated patients. And again, this has been very successful. Again, the biggest difference here is that all the treatment is oral, so it's a lot more convenient for the patients. I'm not going to go to a lot of detail in immune therapy in AML. We have been so far very unsuccessful with both bispecific antibodies as well as CAR T cells. There haven't been many studies of CAR T cells. There are now studies of CAR T cells and CAR NK cells in AML. Hopefully, they will be effective, because we do need immune-based strategies in AML, including bispecific antibodies. And with that, I'm going to end, and delighted to answer your questions.
Thank you, sir, for that wonderful talk. That was fantastic, sir. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Farhad Ravandi.
Can I ask a question?
Yes, please go ahead, sir.
So excellent talk, Professor Ravandi. It's always a pleasure to listen your talks, actually. So one of the revolution which really has happened in the past decade is basically, or past 5-6 years, the venetoclax, which really and azacitidine both really have changed the whole scenario. And in India, in fact, practically, except the teaching hospitals, even for younger patients, I find that the people hardly use chemotherapy 3 and 7. Many patients are being put for the azacitidine and venetoclax. So that is something one. So I was just wondering, like, is there any place for patients who are in remission giving venetoclax as a maintenance? Whether this
Sure.
uh,
So as you heard me saying, I think venetoclax is definitely a revolutionary drug in AML. It's really changed the picture. In terms of maintenance, if you look at the mechanism of action of venetoclax, it's a BCL2 inhibitor.
right.
So it really increases apoptosis. And if you look at the phase 1 trial of venetoclax, which we did at MD Anderson, Dr. Konopleva did it, there was only about 19% response rate. Mainly, most of the responses, a lot of the responses were in IDH mutated patients. So I think the benefit of venetoclax is you give it with something that tries to induce apoptosis in AML cells, be it chemotherapy or azacitidine or decitabine. So do you see what I'm saying? As in, you give those drugs, the cells upregulate BCL2 to try to survive, the leukemic cells, and then you add venetoclax and you inhibit it, and then, your chemo. This is why I actually tell my fellows you can add venetoclax to anything in AML, and you will improve your responses, essentially.
Right.
If you look at all the preclinical of various drugs, I mean, there's like thousands of drugs that people have done preclinical studies in cell lines and patient cells and then mouse models. Whenever they sprinkle a little bit of venetoclax, they all look much better.
Right.
So in terms of maintenance, I'm not sure as a single agent, it would be a highly effective strategy.
Now, secondly, do we have any idea, like patients who are MRD positive at the induction or at the end of consolidation? So do we have an idea, like, who are these patients, like, who are likely to remain MRD positive despite giving the standard therapy, whether it's 3 and 7 or azacitidine plus venetoclax? While some patients are clearly able to become MRD negative, but some are not. So do we have an idea who are these patients?
Yeah, and before I answer this, I just want to add to what I said from my last answer in terms of venetoclax. We actually have had studies looking at AZA plus venetoclax, and more recently, the oral decitabine plus venetoclax in maintenance. So you can actually use venetoclax in maintenance if you add something else. And in our hands, oral decitabine is a perfect drug for that because it's easier. Now, in terms of who remains MRD positive, it's clearly the biology of the disease. Whenever you look at these, if you're talking about flow MRD positive, if you look at AML across the board, the majority of people who remain MRD positive are the more adverse ELN population. P53 mutated patients are always MRD positive. In fact, some people argue, what's the point of doing MRD in P53 mutated AML because they're all positive. There is no MRD negative. Do you see what I mean? This is all this, AML, as I mentioned at the beginning, is not a single disease. There is chemosensitive or treatment-sensitive AML and chemo-refractory or treatment-refractory AML. When I say chemo or treatment. Treatment is now becoming, even, as I showed you, even in AZA plus venetoclax, there's no chemo really, but I mean, there's AZA, but even in AZA plus venetoclax, there is subsets that are much more sensitive and subsets much more refractory, P53 being the most refractory. And this goes back to my first slide, where it all began. AML is not a single disease. There are different biological entities in what we call AML. And the only way we can cure AML is by developing a highly specific treatment, such as ATRA and arsenic in APL.
Right. Just quick, Dr. Amit, one more question. Point actually, I really like this Italian approach that patient with the intermediate risk category and those who are MRD negative going for the autologous transplant. Because that doing auto always is easier than doing the allo transplant. And especially since about 60% of AMLs are so-called intermediate risk category. So at least a sizable number of patients probably can be benefited if assuming like 50% will become MRD negative. So at least you can really benefit a good number of patients by doing auto, which is easy to handle.
I agree. And there was actually also I think either Hovan or German similar study. And I would also tell you, many years ago in Philadelphia positive ALL, there were studies published, and it didn't go far, but there were studies published that showed that patients who were BCR-ABL negative, because those days everybody used to transplant Ph positive ALL, they were showing that if you became PCR negative, autologous is superior to allogeneic. Or similarly in APL, in patients who end up getting a transplant, and our center is never, but wherever there's publications on transplant in APL, you see that the autologous transplant patients do better than allogeneic. In fact, in the US NCCN guidelines, the APL patients, if they relapse, the recommendation is to try to get them PCR negative and then do autologous transplant and do not do allogeneic transplant. So yeah, I mean, these are all the same lines because allotransplant does have toxicity. So the question is, if you become MRD negative, and you want to transplant the patient, it's better to do autologous transplant. Of course, sometime in the future, there will be a situation that people like me and my center will argue, why do we even need to do a transplant?
Right.
Because if you are like, this is what we published in Ph positive ALL, saying that when you become a complete molecular remission, patients do better if you don't transplant them. And there are many people around the world are now moving a little bit away from allogeneic transplant in Ph positive ALL when they become PCR negative.
I think this situation will become maybe in next 20 years' time when we have able to identify the molecular abnormality and have the specific drugs for each of them. Then probably transplant will go very low in number.
I agree. Yeah, I mean, maybe not 20, maybe 10 years, but I'm more of an optimist.
Right. Okay. Thank you.
Thank you, sir. Otherwise, I have your questions.
Okay. Wonderful talk, Dr. Ravandi. And first of all, thank you very much for being with us, Dr. Agarwal, this side. My question is, when relatively very simple and non-toxic treatment with less morbidity and mortality, and we use it for unfit patients at the moment. So do you think a time has come that it can replace pre-transplant treatment for a fit young person? Because if you're going to transplant them, so does it matter whether you achieve the remission or molecular remission with azaven or give them a toxic 7+3?
I think this is a very important question, but I don't think you should do that without having evidence, without having data. The reason for that is that there are some subsets that do really well with AZA plus ven. For example, the best example is NPM1 mutated AML. But there is also the question, NPM1 without FLT3. The question is, do we really want to transplant these people? Does that make sense? That's the subsets that, if there was a 30-year-old who was set on transplant, the patient would come to you and said, I have heard that transplant has to be done because I'm still intermediate risk ELN, and actually NPM1 mutated without FLT3 is actually favorable risk. But yeah, I'm just saying that that population, I'm not sure if you want to transplant. Then there are the other populations that you're not sure if they do better with AZA plus ven. I personally think if you have P53 mutated AML with a high VAF, more than 40%, you're unlikely to benefit from chemotherapy. Maybe in that population, it makes sense to do AZA-ven. There's about 50% chance of achieving a response and then go on to transplant. But you're really taking a chance, because if you give the AZA plus ven to the young 30-year-old in that setting, and they are one of the 50% who don't get a response, you're really keep questioning yourself, oh, wait, should I have given him chemotherapy? Do you see what I mean? So I think this is something that we all struggle with, but I think until we have data, I would not do it in very young and fit people. I would not do it in patients less than 60 who are very fit and have no comorbidities. I certainly would not still put them to AZA plus ven. There is a randomized study that has been conducted by the Mass General, Amir Fathi, that may give us some answer. It's only a randomized phase 2, but still it may give us some answer. I would, be very cautious about doing that outside a clinical trial setting. I think the best thing for you could do is to set up a clinical trial yourself and try to answer that question in a rigorous, statistically proven and IRB monitored setting.
Thank you.
Thank you, sir. Dr. Mukul Agarwal, your question, please.
Thank you. Thank you, Dr. Farah, for a very educated talk. So, a couple of questions from my side. So, suppose if a patient continues to have MRD positive after 1 cycle or 3 cycle of consolidation, how important is it to make this MRD negative before proceeding for a transplant? And what is the best strategy to achieve so?
Well, this was the question that I mentioned that everybody was struggling with. There are papers from Fred Hodge that have looked at this question in a different way, and they just essentially looked at patients who were flow MRD negative versus those who were flow MRD positive, and then went into transplant. And of course, the patients who were flow MRD negative did significantly better, both for relapse-free and overall survival. Similarly, the NIH, Chris Horrigan's papers using molecular MRD, patients who are negative do significantly better. The question is, can you actually convert an MRD positive to MRD negative? And unfortunately, as I said, we don't have excellent MRD erasers. You know, if we had a blinatumomab for AML, I would tell you your question, the answer to your question is very easy. Yes, you need to get them MRD negative. But we don't have a very good. Now, the study that I showed you in my talk from the UK, they used intensification in MRD positive patients, and they did show that that improved survival. So that sort of answers your question. But, you know, for any individual patient, you don't know, because they probably lost some of those patients to the intensification. You know, so overall, it appears that if you convert MRD positive to MRD negative, you do better in the long term. But unfortunately, because our tools are just not perfect, you will lose some patients in your effort to make them MRD negative before transplant. Does that make sense?
Okay.
Now, the only other thing I would also add to this is, again, the Chris Horrigan's papers showing that if you are younger and fitter and you are MRD positive and going to transplant, a myeloablative conditioning is better than a non-myeloablative. So in a young, fit patient who is MRD positive before transplant, use myeloablative condition, not reduce intensity.
And my second question is regarding TP53 AML. So outside of a clinical trial and for our office practice, which is a better regime for induction? Is it intensive chemotherapy or azacitidine venetoclax or something else?
So we have been looking at this extensively in our department, and the answer is VAF. You know what I mean by VAF?
Yes. Variable allele frequency of TP53.
Very allele frequency. If the VAF is less than 40% in a young, fit patient, less than 60, we use intensive chemo. When I say intensive, I mean really intensive chemo, FLAG-IDA plus ven or CLIA plus ven. If the VAF is more than 40%, we use AZA plus ven, even in the younger patient. In fact, what we use is investigational AZA plus ven, so AZA plus ven plus something else. And again, for all of these patients, your goal is to get them to transplant, because we have actually, when we have looked at our data in these patients, the only people you cure are the people who get transplant in first remission, and as soon as possible, because the remissions don't last. If you look at AZA plus ven or VIALE-A, there's about 45% CR rate, CR response rate, and this lasts only a few months. So if you have a P53 mutated patient, you need to put them in remission transplant.
Sure.
And unfortunately, many relapse after transplant. But you know,
Yes.
at least you've given your best shot.
Yeah. And my last question is about specifically mutated AML. Is it a better strategy to give the targeted inhibitor in such scenario, or you can go with a more generic azacitidine, oral azacitidine kind of maintenance for these patients?
Which
For
patients?
all, for specifically mutated patients like IDH or even FLT3 mutated patients, is it better to give the specific inhibitor, or we can go like generic oral azacitidine for all these for maintenance purposes?
I mean, I don't have the FLT3 mutated is easy because there's data. There's a lot of data. And a FLT3 mutated patient, I would use, a FLT3 inhibitor if you have it. Sorafenib, gilteritinib, maybe quizartinib if you have it. In a non-FLT3 mutated patient, if they are IDH mutated, there is very little data. Personally, I actually, if you have it, And if it's available, I would use an IDH inhibitor, mainly because the IDH inhibitors are very non-toxic, even compared to oral azacitidine. In a NPM1 mutated patient, I would use, again, if you have it, oral decitabine plus venetoclax, low doses, very low doses. Because NPM1 mutated AML is very responsive to venetoclax. And also, even IDH mutated, you could argue that you could use venetoclax plus low-dose decitabine. But again, the other major problem with all of these, and I would assume this is a major problem in India as well, is financial toxicity. These oral drugs are extremely expensive. Maybe you have generics in India, but
Not for all of them, sir. Not for all of them.
but yeah, I mean, like you developed Gleevec in India, and it's going like gangbusters. So I'm sure you can get generics of all of these drugs in India.
We have
And
oral azacitidine generics, lots of them, but
yeah,
not for any others.
yeah, and as long as they sell the generics cheaply, I mean, some people developed in the US, the generics are as expensive as the original drug, maybe like $10 cheaper.
Thank you, Dr.
Sure.
Mukund. Dr. Fahima, your question, please.
Very enlightening talk, sir. Kept me at the edge of my chair till the end. So you must have now understood that all of us Indian hematologists love azacitidine and venetoclax. So it's not only for the elderly and the frail patients, it's being used even for the young and fit patients, especially when there are logistic and financial issues, given that we are getting generic venetoclax and azacitidine is hardly 10,000 a month. So now the question arises, how to consolidate these patients, especially when they cannot afford or there's a logistic issue with the transplant. What is your favorite way of consolidation? I did see that in FLT3 you were using a gilteritinib consolidation for up to 24 cycles. But what about other AMLs, non-FLT3 AMLs? What would be the best way to consolidate? And I have another question also, which is immediately going to follow this. With the azacitidine venetoclax, especially in people more than 50 years, the most significant problem we are facing is venetoclax-induced myelotoxicity and myelosuppression and also aplasia. So how do you tackle it in non-transplant candidates? So these are my questions.
So this is why, I understand AZA plus venetoclax probably is easier. You probably are doing a lot of it as outpatient, but
Yeah.
I'm not, I mean, for example, in core binding factor leukemia, you're doing the patient, if you use that for CBF leukemia, you're doing a patient not a favor, because disease RC is very important. Gemtuzumab is very important. So I would definitely not do AZA plus ven in inversion 16 or 821 translocation, because you're jeopardizing patients' survival. Other subtypes, again, I personally, in a younger fit patient, still would not do AZA plus venetoclax in the absence of data. The only group that I would be sort of even potentially is the NPM1 without FLT3, but even that I still would do chemotherapy for sure. Because, I mean, yeah, I know the AZA plus venetoclax has advantages. Probably there's less risk of infection, there's less issue, they don't lose their hair. I'm sure the patients love it a lot more. But I mean, one has to think long term, and are we doing a service to the patient by using a strategy that is not proven? Am I making sense? But even, a fit 62-year-old, in our department, we debate whether we should use intensive or not. Now, if there is a subset that is definitely going to get a transplant, like as I said to you, FLT3-mutated AML, in our department, anyone with FLT3 mutation goes to transplant, particularly FLT3 ITD. In that group, you could argue, we want minimal toxicity initially, so we would use the triplet, AZA plus ven plus GILT. What you're asking is an important question, but this needs to be proven. And in the absence of a good, large database that prospectively shows it's at least equivalent, the strategy, to chemotherapy, I would just be very hesitant. I think another way of proving it is eventually by using MRD assays. If you show that your strategy is as good as chemo, your AZA plus ven is as good as chemo in terms of producing MRD negativity, then despite the fact that the FDA doesn't buy that, I would say, yeah, that's probably good enough information for me to say AZA-ven is equivalent.
So you'll be getting more data, I think, from India, basically with HMA-ven non-elderly or young with some other comorbidities, or even an intermediate ELN, high-risk ELN, that we are achieving MRD negativity, even in high-risk AMLs with azacitidine and venetoclax, not because we want to. First of all, geo is very expensive, have to be imported in our country. And 3+7 has its own financial toxicities, which many of the patients, especially in second-tier cities, cannot afford, or they are not able to travel to tertiary care centers.
I think that's why India is very important, because you can do a lot of these studies. You have how many? You have 1.5 billion population, if I'm correct. So you can actually get together and do such a study in like 3 months.
So I have a patient currently, sir. Currently, I have a patient ASXL1 mutated AML, and just after 3 cycles of ven-aza, she's MRD negative, even by molecular assays and a highly sensitive flow cytometry. Now she is a patient of Turner syndrome with coronary artery disease, hypertensive, hypothyroid. During the first cycle of azacitidine and venetoclax, she had a very bad fungal pneumonia that needed, ventilation. She was in my ICU for 21 days. She was tracheostomized. We brought her out of it, and luckily, even after the first cycle of ven-aza, with just 14 days of ven, she went into MRD negativity. So
But this is very anecdotal. You really need to do the studies, because you guys can do these studies in 3 months and do it in a way that is very meticulous and so nobody can question the data. And then you will publish it you'll publish it in New England Journal of Medicine. And then we will all listen.
So how do we consolidate, sir? So if this patient is unwilling for transplant, so how do I consolidate this patient? So after...
there is no good answer, because, this is your patient is an anecdote. No, there's no history. You will, I'd probably just continue with the AZA plus ven indefinitely.
Okay.
You see what I mean?
So, yeah, I do get you.
Just to give you another example, I had a 97-year-old patient come into my clinic a few years ago, if you were talking anecdotes. And at that time, even with the AZA-ven, everybody was saying, well, she's 97, let's just do palliative care. And I gave her AZA-ven, but with reduced doses. She lived for another 4 years, and that anecdote came that yes, you can treat even 97-year-olds, with AZA plus ven. Am I making sense? So yeah, I mean, you have anecdotes, but in order for people to, I mean, if you go to meetings, everybody comes with one anecdote and says, "Oh, I did this for this one patient." Yeah, inversion 3, that's the worst subtype of AML. Nothing works. I actually had an 82-year-old Indian gentleman who I treated with decitabine and venetoclax for 4 years. This has been in our department the longest living inversion 3 person. So there is always anecdotes there, and so will I go around and say, "Oh, inversion 3 decitabine venetoclax cures everyone"? No, I mean, these are the sort of things that we have to show and prove.
So with available data in elderly AML who have received azacitidine and venetoclax and who are not willing to transplant, so your choice of maintenance would
Continue.
be after 6 to continue azacitidine venetoclax. Okay.
Continue, and then you can actually I would do it indefinitely, because some people say, "Oh, well, let's just do 2 years or 3 years." I would do it indefinitely, but reduce the doses or lengthen the cycles. Actually, preferably reduce the doses and make cycles 4 or 5 weeks. And just make sure they don't get very myelosuppressed. But I would do it indefinitely. And if the patient tells me, "Why are we doing this forever?" I tell them, if you have high blood pressure and somebody gives you blood pressure medicine and controls it, do you stop it?
Okay. That, I think, kind of answers my question. Thank you so much. Thank you, sir.
Thank you, Dr. Kohima. Dr. Rajan Kapoor, your question, please.
Yeah, excellent lecture, sir. My question is about post-allogenic maintenance. So FLT3, you made it clear that we can use FLT3 inhibitors like sorafenib. What about other maybe intermediate and adverse risks? Is there any role of, say, escalated DLI plus azacitidine post-allo?
I don't like DLI. I mean, there are people who believe in it. I don't like DLI. There is a trial called Amadeus that's looking at oral azacitidine, Onureg. I think it will hopefully be reported soon. That's a study that will tell us, because the previous studies of azacitidine post-allo have sort of been negative.
Yeah.
There was one from our center, which was published, I think, in Blood Advances. But it's because they didn't know exactly the doses, some patients didn't do it, etc. So there is, I think, the role of azacitidine post-allo will hopefully be more clear when Amadeus trial is published or reported.
Thank you, Dr. Rajan Kapoor.
I mean, apart from that, if you have a high-risk patient, despite the fact that there is no clear data, I still would use low-dose azacitidine post-allo, because P53-mutated patients, for example, they will relapse even post-allo.
When do you start this azacitidine, like day 100 or so?
There is a paper, it's day 100, and it is definitely reduced dose. So you should look up the paper from Marcus de Lima that shows you the dose. It's significantly lower dose, so please don't give the full dose.
Right.
It's
32.
It's like
32 milligram.
Yeah, it's much reduced dose of azacitidine, and so I would definitely be careful, because you would lose your graft otherwise.
Thank you.
Yeah, 37.5 for 5 days, somebody.
Yeah. Thank you, Dr. Rajan. Dr. Ranjit Kumar Sahu, your question, please.
Yeah. Good evening, Dr. Ravandi, and that was an excellent talk throughout. And I got a couple of questions. I would start with the WHO new classification. I agree that it is more of a genetic classification these days. And you already quoted about the invasion 3 AMLs, that there are anecdotes. What about the other AMLs like the NUP rearranged AMLs or AMLs who are DECNUP, translocation 6-9 AMLs? As of today, there are very small subsets, but do you treat them alike or you treat them differently? That is my first question.
With the the 6-9 translocation, a significant majority of FLT3 mutation.
Yes.
So I would use a FLT3 inhibitor. For NUP98, they are supposedly responsive to menin inhibitors. So I think, I have at my department, I have a luxury of having something like 200 protocols. We're 30 faculty, and many of them young and eager. Many of them have like 10 protocols each. So we have a luxury, and we sit around and we discuss patients. And so protocols are also only good if you use them intelligently. So not just for putting a patient on protocol, but if it is appropriate therapy. So I have the luxury of using these protocols. So for example, if I have a NUP98, we now have a 3+7 plus a menin inhibitor, or we have azaven plus menin inhibitor. So that's something I would consider. Do you see what I mean? And the absence of having the luxury, unfortunately, you have to just treat them as you have until you have those availabilities.
And you feel these experimental regimens could be better than the usual intensive chemotherapy regimens, sir?
No, I didn't say that. I think, we thank every patient when they go on our trial, and we sit down with them and give them exact, this is the standard, this is the investigation, this is the potential benefit of investigational, this is the advantage, this is the disadvantage. And they have to sign the consent before they go on the trial.
Right.
So, if I knew that it was better, then I wouldn't do it on a trial. And this is why I keep telling you guys, AZA plus venetoclax in younger patients sounds very interesting, but I wouldn't do it until I have data. Or if I'm doing it on a trial. If I had a really nice randomized trial that clearly, without bias, randomized patients to either, and the patients had informed consent, they fully understood what they were doing, I would do that.
Right. So we lacked a perspective here, sir. Let me first tell you what is happening to the AML patients in our country. So the median age of AML in our country is in the late 30s or early 40s. So our patients are younger than what you treat at MD Anderson Cancer Center. Now the second thing is, it is not because it is because of the population structure in India. So more than 60 years, unlike in US, in India it is only 9%. So most of the AMLs that we see in our clinic, they are the late 30s and early 40s.
Yeah, I know.
Now, that makes all the patients that are coming to our clinic curable by just age.
Yeah.
The problem is, when we attempt cure at these patients in the last 5 or 10 years, the early mortality are in excess of 30 to 70% across all the centers. This is a data I am quoting from a multi-center analysis, which is retrospective. So you could understand the induction mortality in the first 30 days, at least in India, it is in double digits.
Yeah.
So that is the fear. I mean, we lack this perspective to tell you why the physicians across the country are willing to use more azaven and include these patients to do a BMT when they are stable. So that is our perspective. So a fit patient in MD Anderson Cancer Center with an induction mortality of 5% or less, we should not think about it, think about azaven. But when the induction mortality is going, let's say, let's keep it as more feasible and palatable at 25% in India, which is still less, I would say. 3 and 7 inductions could be a little tricky in our set of patients.
Yeah, that's,
So,
I mean, you have a very good answer and very appropriate. And what I would recommend you or someone in India do is collect all these data. This would be retrospective. The Canadians did this many years ago with rituximab
right.
in I can't remember, follicular lymphoma or large cell lymphoma. They looked at the time when Rituxan was approved, and they looked at the outcome of the patients post that time. Majority, almost all, were treated with Rituxan as compared to before that time, where no
Right.
Rituxan. They did show there was a clear advantage. You can
Absolutely.
actually do this if you have the database. You can look at the outcome of Indian AML patients before and after AZA plus VEN.
Yes.
And if you
And
clearly show their outcomes are improving, you've answered your question.
yes, I completely agree. And there was an induction mortality calculator which was actually developed in the MD Anderson Cancer Center, and
Yeah.
I'm not able to quote this study and the publication that I have read a few years back. And patients where this induction mortality is high, when there is a randomization between induction with intense chemo versus decitabine and venetoclax, decitabine was possibly used as a 10 days regimen here. Decitabine venetoclax actually resulted at a better survival in this patient. So that
That
is
was in
one.
the older patients.
Yes, yes. So especially
No, of course.
where
I mean, this is why even, we haven't been using chemo in patients over the age of 60, 65 since early 2000s, when we just used single agent, other agent, because the mortality was too high. I agree with you. In India, you may have the situation in younger patients, but, let's say you have a very fit, healthy, and extremely wealthy younger Indian patient,
right.
and you put them in a private hospital, and you get your best staff and everything. Do you treat them with chemo or with AZA plus VEN? I mean, you could do AZA plus VEN, I guess, and then transplant, but
No. There are patients who are still receiving these chemotherapies. Now,
yeah,
I am talking about a data which is from our institute, which is an academic institute. And this data happened in an era where the induction mortality was only 12 to 15%. Now, our long term, the median age is 30 years. Our long term data in this close to 300 patients were only 35% on the long term. So even though let's say we are losing 30% patient in the first 30 days, that makes it 70 at the end of first month. Close to 50% of these patients are relapsing with the 3 and 7 regimens. And the overall outcome at 5 years is 35%. So if we just go by the age, let's say these are late 30s or early 40s, we would have been happy if the long-term outcome should be close to 45 or 50%. So even though we are saving let's say some of these patients, let's say 30% are dying in the first month, still the long-term outcome of AML, even in this age group, it's not great. So there should be, now what we are planning is we are giving them less intense therapies. We are allowing them to get the funds because the penetrance of insurance is very, very less. If I have to put a number, it should be somewhere around 5%. And these patients are 30s or 40s. So that is the age when these patients are actually earning the bread for the family and themselves. So they require some time to arrange funds. So the issues in this part of the country could be a little different than what happens in the US. So that's why you would have understood that many physicians, they are not recommending as a frontline regimen. Anybody would for the fittest patient, anybody would use chemotherapy, but the amount of funds and that is required in the ensuing 2 to 3 months, it could be very tricky.
No. So I mean, I totally understand and get what you're saying, and I agree with you completely. And all I'm just saying is, if you ask me in my setting, I would not do it. But
Yes.
of course, we unfortunately live in different worlds, and
Yes.
you have to do what you have to do. And
Yes.
if you remember in one of my slides, I say I actually would love to retire 3+7.
Yes. Yes.
I
So yeah.
think the only way we can do that is by developing effective targeted agents, adding them at the moment to AZA plus venetoclax, and making sure that these targeted agents do not break the bank, because
Yes.
if
So
the oral agent is 10 times the cost of 3+7, nobody's going to take that.
yes. So all across the country, because venetoclax is still not available as a regular generic here, all of
Yeah.
us we use with azole. And if it is POSA, it is 50. If it is itraconazole or voriconazole, it is 100. Now, my next question is for the FLT3 ITD positive AML patients. Now, you are sending all these patients to BMT at CR1. Now, if you are sending all these patients for bone marrow transplantation, so what is your regimen of choice? Is it intense chemo plus FLT3 inhibitor, or azaven FLT3 inhibitor? Let it be Gilter.
As I mentioned, in the younger fit patients, we do the intense chemo, like the CLIA plus a FLT3 inhibitor. Used to do sorafenib. More recently, we're doing CLIA plus gilteritinib. In the older patients above 60, we use azaven gilteritinib, or more recently, we have decitabine ven plus quizartinib.
Okay.
Lower intensity. All of these are done on clinical trial, as in every patient signs a consent, understands that there are potential risks. So far, we have done beautifully. We haven't had anything that's unexpected.
Right.
We actually, for a while, we were doing CLIA-VEN plus sorafenib, and that was associated with, in the first few patients, with higher toxicity and mortality, so we abandoned that.
Okay.
So we don't combine venetoclax and sorafenib and the chemo, intensive chemo. We just use CLIA plus gilteritinib. So this is the point of doing these things on trial,
Sure.
because when you are on trial, you monitor the patients. If in your first 6 patients, 2 of them do badly, you panic and you hold the trial and say no more patients.
Right.
Does that make sense?
Yeah, absolutely.
Whereas if you do it anecdotally, the first patient might do beautifully,
Yes.
and then you go and advertise and are all around India, and the next 3 patients in other centers, they all die on day 15.
I
And
agree.
they're all going to come and say, Dr. So-and-so is telling us, he just wanted to do these things because he wanted to become famous, blah, blah, blah.
Yeah.
Does that
So
make sense?
even at our center, we are looking into how much venetoclax we need to add to intense chemo regimen. We use a 3 and 7
Yeah,
mg.
and you have to be very careful. And
Yes.
all of these has to be done in a very Bayesian. All of our strategies are done in a Bayesian fashion, as in we
Absolutely.
constantly monitor the data. Our
Yes.
statisticians are monitoring. I mean, our statistic department is bigger than our leukemia department.
Right.
They constantly monitor these responses and toxicity, and if there is some red flag, it just goes up, and the institution shuts us down.
Right. So our results are quite different than what we see in the West or maybe some Chinese data. So we do not feel extending venetoclax, because we use it with azole. Extending venetoclax beyond 5 days is also very toxic in our set of patients. And even in 3 and 7 is not so, I mean, easy. It is very intense.
No, it's going to be very, I mean, probably not as myelosuppressive as flagoidaven or cleaven, but
Yeah.
you know, the Italians started doing this, and I would go and tell Martinelli, be careful, be careful.
Yes.
You
So
know,
yes,
because
yes,
again, we don't want to advertise something that people use in the community and then everybody's dropping dead. And then they come back and say to us, oh, look, MD Anderson, they always come up with everything is 100% response, blah, blah, blah. The reason why it is like that is because we have dedicated team. We have, I don't know if you guys have the luck. I don't ever treat a lymphoma patient.
yes.
I don't even know what breast cancer is.
Okay.
Despite the fact that I'm a hematology oncologist, I only treat leukemia.
Yes.
And not just me, all my nurses, all my staff, everyone just does leukemia. Of course,
Yes.
that setting is very different than, a community hospital in Madras or in Chennai.
Yeah.
Am I
So
making sense?
yeah,
So
that
this is why when I give the talk, I say this is very myelosuppressive.
yes, this is
Be careful, blah, blah, blah.
yeah.
We give prophylactic antibiotics to every one of our patients.
Yes.
Not that that's going to be a cure or prevention complete, but, and so, there are nuances to what we do just because we are a super, super specialized center.
Yes. So I was
May
actually
I
at the
intervene?
yeah.
I think this is 8:45.
Sorry.
Discussion on this front for a long time. These are two very geographically different situations and socioeconomically different situations. So let us just have a few questions now to Dr. Farhad, if at all. Otherwise, we call it a day. But this can be an endless.
One last question, sir.
Yeah.
Okay.
So you have used all the protocols. I mean, this cladribine, fludarabine, and you have not mentioned about clofarabine. I have read some of your papers. So which of this antimetabolite is the ideal agent to be combined with RSC, with or without venetoclax and idarubicin?
Clofarabine, unfortunately, is a bit of a dead drug in the US. So we don't use it anymore. And I don't even know if pediatricians still use it. But the last time I used clofarabine was 15 years ago or even longer.
Okay.
Cladribine, I think, is an excellent drug and is cheap. And there was a Polish randomized study a few years ago published in JCO.
Yes.
That did 3+7 versus 3+7 plus fludarabine versus 3+7 plus cladribine. And it appeared that cladribine was a better drug for whatever reason. So we are a big fan of cladribine. We will, that's where I put it. Okay, well, thank you very much. It was exciting, and I hope you enjoyed it, and I definitely enjoyed it.
Thank you so much.
Thank you.
Should I go for 4 or 5 questions more, because there was few questions in the chat box?
Only if Dr. Ravandi has time.
Yes. Should I go?
I really have to go. Maybe just one more, please.
Yeah. Just a couple of 3-4 questions, one line questions only. I have narrated. So regarding if the patient is to be started on oral azacitidine post HIDEC, which are those patients to be started on oral AZA post HIDEC? Which patients you will start on oral AZA post HIDEC consolidation?
I mean, the study that was published was in patients who are not eligible for transplant, so it could be any patient.
Okay. And if the patient is the treatment same for FLT3 ITD and TKD both?
I'm sorry?
Patient, whether it is FLT3 ITD and TKD, does it matter, sir? Or whether the treatment is absolutely same? Whether ITD or TKD?
Well, TKD is actually probably not as bad as ITD. Many studies have included TKD, so we still, behave as if TKD is somewhat similar to ITD, but in reality, TKD is not as bad as ITD. But I still treat it the same as ITD, with the exception that quizartinib does not work in TKD, or sorafenib for that matter.
And if you want to continue the
against
patient,
ITD.
Amit, last question.
Last question. And if the patient has to be continued on midostaurin post-transplant in case of FLT3 ITD, how long will you continue the same?
To be honest with you, I almost never use midostaurin because I think it's not a very good drug, and in my opinion, it will become obsolete after quizartinib gets established. The Ratify used midostaurin for about a year, but even in the Ratify trial, the maintenance question was not clear, as in they weren't able to show that midostaurin maintenance was useful. I believe midostaurin TKI, FLT3 ITD TKI, FLT3 TKI is useful for maintenance. I don't really think midostaurin is a good drug for any setting. I mean, I'm sure if you talk to Dr. Richard Stone, he will tell you otherwise, and I would tell you that I have been involved in development midostaurin from the early days, from the phase 1 setting, because the phase 1 was actually done at MD Anderson, a lot of it. So I would tell you midostaurin, in my opinion, is even a worse drug than sorafenib.
Thank you, sir. We'll not take much time of yours now because already it's 9 o'clock over here.
Yeah.
Thanks a lot for the wonderful lecture, sir, and what a wonderful discussion.
All right, thank you.
And I now hand over to Zydus for the final vote of thanks.
Before you do that, Dr. Ravandi, I apologize. There was a discussion which went on a tangent, totally. The whole goal of this was education and scientific discussion, but the geographical situation and the socioeconomic impact of the discussion was totally different. And the young blood had their experiences to share. I apologize for that.
No, that is very good to have a discussion. I mean, without discussion, we are just
thank you so much.
Blind sheep.
Thank you so much.
Thank you.
Yeah.
Thanks again.
Thank you, Dr. Ravandi, for sparing your valuable time. It was a wonderfully crafted presentation and a wonderful discussion we had. We have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Purana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everybody, and have a wonderful weekend.
Bye. Thank you.
Bye.
Again, thank you, Dr. Ravandi.
Thank you, Dr. Agarwal. Thank you, Dr. Amit.
Thank you.